Basic medical sciences, welcome back. If this is your first time, please make sure you subscribe so that you won't miss any of our latest videos, right? And if you are a returning subscriber, thank you so much, right? So today again, I decided to show up my face because I'm going to talk about a very important vitamin, right? So I need you to look me in the eye and promise me that you will remember this vitamin, right? Okay, so I'm talking about vitamin B9, also known as folic acid or folate, right? So this vitamin is very important. Please, you need to pay attention, right? So let's get into it. So we'll start with the general characteristics of this vitamin, right? So the active form is called tetrahydrofolate, right? THF, tetrahydrofolate, or tetrahydrofolic acid is same thing. What are the sources of this vitamin? Leafy green vegetables, right? So you can say, because those leaf green vegetables, they are also referred to as what? Foliage, right? Foliage, right? You can remember it that way. And also fortified foods like bread, flour, and cereal, right? Another source is intestinal flora, because small amounts of this vitamin are synthesized in intestinal flora, right? So what is another vitamin that is synthesized from this intestinal flora, right? Is vitamin K, right? Vitamin K, we'll talk about it later, right? Moving on to resorption, right? This one is specifically, it happens in the jejunum, right? Jejunum is the second part of small intestine, right? Via specific transporters. And in blood is transported via folate binding transport proteins, right? Vitamin B9 is one of the few vitamins that are stored in the body, right? So I told you in our introduction videos that vitamin B9 and B12 are stored in the liver for some time. B9 is 3 to 4 months and B12 is 3 to 4 years, right? Okay, so here for storage, small reserves in the liver, right? Approximately 3 to 4 months, right? The an important fact here, you need to remember that this active form, tetrahydrofolate, is obtained after reduction of folate by dihydrofolate reductase, right? This enzyme is very important, as you're going to see in the next slide, right? Particularly in DNA synthesis, right? Okay, let's see what we have here, right? So let's talk about the functions of folic acid, right? Tetrahydrofolic acid or tetrahydrofolate, the active form, is a coenzyme of one carbon transfer, right? So if you know general formula is CH3 is a methyl group, right? So those reactions, like we can say, like there are methylation reactions, right? Particularly important for synthesis of nitrogenous bases in DNA and RNA, right? So this scheme, I used it in biochemistry croc 1, right? So you can check on our playlist and you will see this. I explained it in very great detail, right? So there is a stage where deoxyuridine monophosphate is converted to deoxythymidine monophosphate, right? This reaction is mediated by thiamidylate synthase, right? Thiamidylate synthase. This enzyme called thiamidylate synthase needs a coenzyme of what? Methylene tetrahydrofolate, right? Or let's just say tetrahydrofolate here, right? So if it take part in this, it will be converted into what? It will be reduced, right? Into dihydrofolate, right? Dihydrofolate. To convert dihydrofolate back to tetrahydrofolate, we need dihydrofolate reductase, right? We need this enzyme, right? So there are some drugs which you need to know, drugs which inhibit this enzyme, right? I talked about it in that Croc video, right? So the drugs include methotrexate, trimethoprim, and uh, pyrimethamine, right? Pyrimethamine. Okay, my pronunciation, excuse me there, right? Okay, so this is the basic function of this vitamin, right? Okay, now let's talk about deficiency, right? So deficiency is very important, and I told you this part is the main reason why I decided to show up my face like this, right? Okay, so folate deficiency is the most common vitamin deficiency in the US, right? So we will talk about etiology. What causes this vitamin B9 deficiency? Clinical features, diagnosis, treatment, etc. Right. So let's start with etiology, right? So there are four main things which you need to know, right? Malnutrition, malabsorption, increased requirement, and drug-related deficiency, right? Let's start, right? So on malnutrition, you need to remember like insufficient intake. For example, those people who stick to diets like tea and toast, and also chronic alcohol use can also lead to folic acid deficiency. The second one, malabsorption, right? So small bowel diseases such as tropical sprue, celiac disease, inflammatory bowel disease can cause this folic acid deficiency, right? Because the absorption will be disturbed, right? And also surgical resection of small intestines, right? So if you do like if you do resection and then perform that end-to-end anastomosis, the surface area for absorption will be very small, right? So that one can interrupt absorption, therefore folic acid deficiency here, right? Another one, right, number 3 is increased requirement. Increased requirement occurs particularly during pregnancy and lactation, right? I will talk more about pregnancy later, right? And another condition which increases the requirement of vitamin B9 is severe hemolytic anemia. Severe hemolytic anemia, right? And lastly, we'll talk about drug-related, right? So drug-related deficiency. This will be caused by drugs like methotrexate, right? So methotrexate, this one I told you, this drug is an inhibitor of dihydrofolate reductase. Another group of drugs which cause folic acid deficiency are anti-epileptic drugs like phenytoin. Sulfonamides can also cause deficiency of folate deficiency. Can also cause deficiency of folic acid. Okay, and trimethoprim, right? Trimethoprim again is an inhibitor of dihydrofolate reductase. Right. Let's talk about pathophysiology, right? What happens here exactly? Right. Decreased folate levels leads to decreased level of the active form, that's tetrahydrofolate, right? So if tetrahydrofolate is very low, this will lead to following effects, right? Firstly, we have decreased DNA synthesis, right? Decreased DNA synthesis will lead to megaloblastic erythropoiesis and consequently megaloblastic megaloblastic anemia, right? So it's a kind of macrocytic anemia where the red blood cell will be very large and also containing nucleus, right? Because normally RBCs, they don't have nucleus, right? So in this case it will have nucleus and uncondensed chromatin, right? Another condition is decreased methionine and increased homocysteine, right? So stop right there. I want to show you methionine cycle, and then we'll come back to this point so that you understand it better. Right, so this is methionine cycle, right? So methionine is converted to S-adenosylmethionine. Then S-adenosylmethionine is converted to S-adenosyl homocysteine. S-adenosyl homocysteine is converted to homocysteine, and then homocysteine is converted to methionine, right? So this cycle, the most important part is this one, right? So I will talk about it last, right? So let's start. Methionine to S-adenosyl methionine, it needs ATP, right? So it will give off ADP and an organic phosphate. Conversion of S-adenosyl methionine to S-adenosyl homocysteine is just shifting of methyl groups, right? So it's performed by methyl transferase enzymes, right? And then homocysteine can be converted to what? I mean, S-adenosyl homocysteine is converted to homocysteine, and then homocysteine back to methionine, where we started, right? So this stage, I said the important one, is mediated by an enzyme called methionine synthetase. This enzyme called methionine synthetase, it uses 5-methyl tetrahydrofolic acid as a core enzyme, as a core factor, right? So giving what? Tetrahydrofolate, right? So 5-methyl tetrahydrofolate is what we need here, right? So if there is deficiency of folic acid, so it means 5-methyl tetrahydrofolate, right, is very low. It cannot help methionine synthetase to mediate this pathway. What will happen is that there will be accumulation of homocysteine, right? There will be accumulation of homocysteine, right? And since this reaction is not taking place, it means methionine will be very low, right? Methionine will be low, right? So this pathway, you need to understand it because, all right, so what I just told you is related to folic acid only, because I want to tell you another thing from here, because homocysteine is another pathway. If you know the disease called homocystinuria, right? So homocysteine can form cystathione, right? Cystathione can be converted to cysteine, right? Cysteine is an amino acid, right? So conversion of homocysteine to cystathione is mediated by an enzyme called cystathione beta synthase, right? So this enzyme, right, if a child has a deficiency of this enzyme, is actually an autosomal recessive disorder, right? So the child will have homocystinuria, right? So the features of homocystinuria include what? Marfan habitus, like pectus carinatum, pectus excavatum, right? Very large limbs, etc. It's something like those are Marfan syndrome related conditions, right? But okay, let me just finish the pathway, and then I will tell you the most important clinical features of these two and how to differentiate them, right? So for synthesis of cystathione, homocysteine combines with an amino acid called serine, and also this pathway needs vitamin B6 pyridoxine, right? conversion of cystathione to cysteine is just is actually a cleavage, so it's cystathionase, right? Okay, so let's go back, right? So as I just mentioned, cystathione is very low, homocysteine is very high. Right, so if homocysteine is very high, this will lead to endothelial damage, increasing the risks of cardiovascular diseases and thromboembolic or thromboembolic events. Right, so these two are the main causes of morbidity and mortality in patients with what folic acid deficiency. And guess what, again, in homocystinuria, right? So how to differentiate them, like the causes etiologically, right? So patient used to tell you that this patient has a deficiency of this vitamin, right? That's why you will see that like the other pathway for homocystinuria, there is deficiency of what? Cystathione beta synthase, right? Okay. Then another condition here, another effect, right? So during fetal development, you need folic acid, right? So if there is deficiency here, there will be what? Nucleotide synthesis impairments leading to neural tube defects, right? So neural tube, it is like an anterior neural pore, posterior neural pore, right? The anterior neural pore, it closes on the 25th day, and the posterior on the 27th day, right? So what happens is, like, if there is deficiency of folic acid, they can be like like closing will be difficult, closing of the neural pores will be difficult, or they may not close at all, right? So you just need to keep that in mind. And also aberration of DNA methylation, right, which will increase the risks of cancer, right? So these are the features associated with what? With lower levels of tetrahydrofolate, right? So now let's talk about clinical features, right? Clinical features are not so difficult here on folic acid deficiency, right? The first one is anemia, right? Signs of anemia like fatigue or pale skin, etc., right? Different signs of anemia, right? Another one is glossitis, and if we talk about maternal deficiency, right, this will lead to conditions like fetal spina bifida or anencephaly, right? So spinal bifida, there is spinal bifida, cystic. Okay, it's a lot, but just to know even this one, if you don't know what spina bifida means, Google it, you'll see the pictures, right? Okay, so this part is very important. You need to know, right? So unlike vitamin B12 deficiency, folate deficiency does not result in neurological symptoms, right? Because you will see that the anemia basically is actually, it's almost the same. Megaloblastic anemia is almost the same, right? So outside the lab, this is how you differentiate it. If you see like that megaloblastic anemia, but this patient doesn't have any neurological symptoms, then you need to suspect folic acid, right? I will talk about it again in vitamin B12, which is going to be our next video, right? So stay tuned, right? Now let's talk about diagnosis of vitamin B9 deficiency, right? Firstly, there is a macrocytic megaloblastic anemia, right, where there is increased mean corpuscular volume of greater than 100 microgram This one, how do you name this? How do you read this one? It's cubic micrometer. I don't know. Okay. Or I usually use this femtoliter, right? Femtoliters. I use this one because like the normal level is like 80 to 100 femtoliters, right? That's MCV in normal, right? So in megaloblastic anemia here, you will see it's more than 100 femtoliters, right? Then another thing which you see, because I said there is that pathway from homocysteine to methionine, is that pathway is disrupted, so there is accumulation of homocysteine, so you will see homocysteine, right? So this is how you differentiate it from vitamin B12 megaloblastic anemia, right, in the lab. About neurological symptoms, it's outside the lab, right? Okay. Then another one, methylmalonic acid, right? This one I will tell you about it in the next video when we talk about vitamin B12, right? So in this case, in vitamin B9 deficiency, its levels are normal, but in vitamin B12, the levels of methylmalonic acid is high, right? So I will remind you again, right? Another feature here on diagnostics, you also see hypersegmented polymorphonuclear cells. About folate serum levels, right? Like people also need to know the levels in general is like 2.5 to 20 nanograms per mil, right? But you need to remember that in diagnosis, the folate serum levels are not reliable, right? They are not reliable. So if folate deficiency is suspected, always exclude the possibility of vitamin B12 deficiency, right? Is a very important point here, which you need to remember, right? So to conclude this video, let's talk about treatment of vitamin B9 deficiency, right? So firstly, oral folate supplementation for 4 months or until hematological recovery take place. Secondly, nutritional counseling to increase folate intake. And this one is about a pregnancy, right? So because of the risks of neural tube defects, which I told you, it is recommended that women planning to become pregnant initiate folate supplementation before conception, right? So thank you so much. If you like this video, please make sure you subscribe so that you won't miss any of our latest videos, right? Goodbye. Paka. Okay, guys, the other thing, please tell me in the comment section if these videos are actually helping you, right? And also share with other friends so that more people will come. I also have a bigger audience, because if a lot of people are watching the videos, I will try to make these videos like every time, and also I'll try to make them nice, improving the animations. You also suggest, just use comment in the comment section so that you tell me what you want, right? Some people asked me about pharmacology, right? So I started pharmacology videos, right? So but I will focus on biochemistry for now, but pharmacology here and there I will be posting videos maybe once in 2 weeks, right? So have a nice day.